Good morning, everyone. My name is Swati Naik. I'm an associate member at St. Jude Children's Research Hospital. First, I'd like to thank Alice for the kind invitation to this outstanding symposium and congratulate her and the team on its success. It's my great pleasure and privilege to moderate this session on advances in leukemia, and we have three outstanding speakers. The first, we'll hear from Dr. Peter Lang, who is a professor and head of the Pediatric Stem Cell Transplantation Unit and medical director of the Department of General Pediatrics and Hem/Onc at Children's University Hospital Tübingen in Germany. His research focuses on the development and improvement of immunotherapeutic approaches for both heme malignancies and solid tumors in pediatric patients. And today he will talk to us on the use of an alpha beta T cell deplete CD19 deplete haploidentical transplantation approach for children with acute leukemia. Dr. Lang.
First, I would like to thank the organizers for giving me the possibility to report on our experience. Thank you very much for this kind invitation. So our institution focuses on graft engineering since about 20 years. We started 1995 with CD34 selection of pure stem cells. Then we switched to the CD3, CD19 depletion in 2000. And we now use, of course, the alpha-beta CD19 depletion. So I would like to show you our clinical results. First, the results of a prospective multi-center trial in pediatric and adult patients. And second, our single-center results between 2012 and 2023. So the study designs of number one was a multi-center open-label phase 1/2 trial with 6 pediatric and 7 adult sites. We had 30 pediatric and 30 adult patients, and the primary objective was to analyze the safety and feasibility. These are the depletion results. We ended up with a 4.68 log depletion of alpha-beta cells and a 3.36 log depletion of B cells. And as you can see, the method was very robust in our hands without any outliers. Most patients had acute leukemias, but also some solid tumors and non-malignant diseases. Only about half of the patients achieved a complete remission, and 36 patients received a second or even third transplantation within this trial. And that is the conditioning regimen. We started at day -12 with ATG in order not to harm the co-transfused cells at day 0, and this is the backbone of fludarabine, thyrethepa, and melphalan, and MMF was given until day 30. So this is the graft composition. We infused a median number of 12 million stem cells with only 40,000 per kg residual alpha-beta T cells, 37,000 residual B cells, and we co-transfused high numbers of NK and gamma delta T cells. The engraftment was fast, with a median time of 13 days to reach 500 neutrophils and 15 days to reach independence from platelet transfusion. And we saw initial engraftment in 52 out of 60 patients. In 7 patients, a reconditioning and a second donation was necessary, so a final engraftment occurred in 59 out of 60 patients. And that is the acute GVHD, no grade 3 to 4, only 10% grade 2, and 9% severe chronic GVHD. Here you can see the immune reconstitution. We saw 147 CD3 per microliter at day 14, about 260 at day 100. In the very early post-transplant phase, gamma delta T cells were the predominant population, then followed by alpha beta T cells. Later on, there was a switch, and alpha beta T cells represented the predominant population. The reconstitution of NK cells was very fast, and we could reach normal CD19 numbers already at day 63. This is the gamma delta T-cell receptor repertoire of the donors, which was very similar to that in the patients, already starting at day 28, then 63, and day 100. And this is the number of T-cell receptor excision cycles in the donors at day 28 and day 63. We could detect tracks starting at day 100. That means at that time point the de novo generation of naive T cells started. This is a comparison of CD3 recovery after the old CD34 selection procedure and the alpha-beta selection procedure. At day 30, we found a significant faster T-cell recovery after alpha-beta than after CD34. This is also true for day 90. Later on, there was no significant difference anymore. The infections in all patients, adults and pediatric patients, the major pathogens were CMV and adenovirus. However, only 3% of the patients developed disease, but 18% in ADV. And these were exclusively pediatric patients. This is the reactivation of ADV, CMV, and EBV only in children. We found 60% reactivation of ADV in stool, 40% reactivation in blood, whereas CMV reactivation was low, only 20% in urine, blood, or throat. And interestingly, we found no EBV reactivation, probably due to the profound B-cell depletion. This is the outcome in all patients. The overall survival was 60%, disease-free survival about 50%. Relapse was found in 30%, and a non-relapse mortality at day 100 of 5%. This is the disease-free survival of patients in complete remission, the red line, and the relapse rate in patients with complete remission of about 28%. This is the outcome of patients who received a first transplantation or a second or higher transplant. Of course, this outcome was lower, but second transplantation is definitely possible. And this is the disease-free in children with acute leukemias and myelodysplastic syndromes with 60% in CR at 1 year after transplantation and 40% after 2 years. The transplant-related mortality at day 100 in children was 5% and reached 15% at 1 year. This is the relapse rate in patients with any CR of 15%. So in summary, this trial showed that infusion of large numbers of stem cells, NK and gamma delta C cells, is possible even in very small children without exceeding the limit of alpha beta T cells. And this was 25,000 in our hands. So officially it was 50,000, but I got a bit nervous if we exceeded 25,000, which was normally not the case. High depletion efficacy resulted in low incidence of GvHD. We had an acceptable treatment toxicity. We saw an accelerated immune recovery. However, the viral reactivation still needs improvement. And the short course of immune suppression offers the possibility of additional cellular therapies post-transplant. Now let's switch to our single-center results. In total, we transplanted 138 patients with alpha-beta depleted cells. Most patients had acute leukemias, and these are only pediatric patients of our institution, ALL and AML, but also a significant number had solid tumors and, of course, also non-malignant diseases. 30% still had active disease, and this also includes MRD positivity. And CR1 or 2 or higher occurred in 40%. So these are the number of transplantations. As you can see, 54% received a second or even a third or a fourth transplantation. So only half of the patient had first transplantation. And this is the acute and chronic GVHD in our own patient population, also very low. Acute GVHD, 4%, grade 2, 8% grade 3 and 4, and only 3% extensive chronic GVHD. This is the outcome according to diagnosis groups: leukemias, solid tumors, and non-malignant disease. And this is the event-free survival in ALL according to remission status. You can see here the gray line, which is CR1 and CR2, about 50%, and also patients in CR higher 2. This is the yellow line, had a very similar outcome, whereas patients with active disease or too high MRD could not be rescued. This is the event-free survival in AML. Again, patients in CR1 and 2 did very well with 75%. And also some patients with active disease could be rescued in AML. This is the event-free survival in solid tumors. The blue line depicts patients with metastatic relapsed neuroblastoma. These patients have been treated in a separate trial. All these patients have received dinutuximab beta after transplantation, whereas patients with other solid tumors did poor, probably due to the fact that we had no immunotherapy for these patients afterwards, whereas these patients received the antibody-based immunotherapy. This is the event-free survival according to number of transplantations, first transplantation, and also patients with second transplant did very well. We found favorable results for a second transplantation, probably due to the low toxicity of the conditioning regimen. So these are the current problems, in my opinion, which have to be addressed: the ATG dosing, viral reactivations, and the relapse rate. Here you can see ATG serum levels after various dosing schemes. In principle, we preponed the start of ATG to day -12 in order not to harm the co-transfused cells at day 0. That means we have a rejection prophylaxis during the conditioning regimen, but no further in vivo depletion after day 0. And here you can see the ATG levels after a total dose of 15 milligram per kg body weight ATG graphalon, after 30 milligram per kg, and after 60 milligram per kg. We end up with the 15 milligram at day 0 at a level of 1 microgram, and with the 30 milligram at a level of 3 microgram per ml. And these concentrations are low enough not to harm most of NK and gamma delta T cells. We have checked that in vitro. And there is another interesting fact. Here you can see the same ATG levels, but here shown on a logarithmic scale. And as you can see, irrespective of the ATG dosing, the concentrations decline nearly in parallel. So this is compatible with the linear first-order kinetics. And the values for the half-life time are almost congruent. In the 15 milligram group, 5.4, in the 36.6, and in the 67.6. And this allows us to do the following calculation. So the time until the desired target concentration at day 0 can be calculated by the ATG level measurement at day -5. That means we only have to measure the ATG level at day -5, and then we can calculate if we have to postpone the day 0 until the ATG level reaches the desired level. Of course, this will be only possible if stem cells are cryopreserved, but it is an option. These are the effects of ATG on the graft rejection. The lower the ATG doses, the higher the rejection rate. 15 milligram high rejection rate, 60 milligram low rejection rate. The effect on GVHD was not clear because we already had a very low level of GVHD, acute and also chronic GVHD. And this is the effect of ATG dosing on the post-transplant T-cell reconstitution. You can see here the T-cell numbers at day 30. And we had significantly higher T-cell numbers in the 15 and 30 milligram subgroups compared to the 60 milligram subgroup. And that was also true for day 90. The 30 milligram group had significantly higher T-cell counts than the 60 milligram group. Later on, at day 1 year after transplantation, there was no significant difference anymore. So let's switch to the second issue, viral infections post-transplantation. Here we are able to adoptively transfer antigen-specific T cells. You can see the example of patients with CMV reactivations. These patients had no CMV T cell response prior to adoptive transfer. After adoptive transfer, there was in vivo proliferation of specific T cells in 2/3 of the patients, and exactly these patients were able to reduce or to get completely rid of their viral load. And these are our real-world data with an automated production and treatment with specific T cells on a clinical standard basis. Out of 26 patients, 17 patients showed a response, either a straight response or a transient response with final cold control. So these patients were able to reduce or to eliminate the viral load after use of specific T cells. So we recommend a preemptive and a really early use of virus-specific T cells, or maybe the use of CD45-RA depleted DLI instead of the positive selection. And here a prospective clinical trial is currently ongoing in our institution and also in other institutions. And number 3, the relapse rate. Is there influence of the conditioning regimen? Obviously. So in our cohorts, we had in the multicenter trial, 100% received the melphalan-based conditioning regimen. In our single center experience, 90%. And we found a 5-year EFS of 50%. In the trial of our Italian colleagues, or former Italian colleagues, 75% received TBI, and they found EFS in 71%. So the question is TBI superior also in Haplo? As has been shown in the forum trial for matched unrelated donors? Of course, there is a very big influence of MRD, as Michael demonstrated yesterday. Maybe if a completely MRD negative patient does not need TBI. So we have to evaluate that in the future. So we have observed stable results in ALL, AML. Perhaps there is an improvement possible with TBI in a subgroup of patients. Second transplantation is definitely feasible, and I think also due to the low TRM of the methylene-based conditioning regimen, we never would use a second TBI, of course. The improvement of immune recovery might be possible by reducing the ATG or augmenting the time between application and day 0, by the early use of virus-specific T cells, and probably by the addition of CD45 RA DLA after transplantation. So finally, I would thank all my colleagues in different centers and in my own center in Tübingen, and especially Rupert, who founded all these things. Okay, thank you very much for your kind attention.
Hi, Peter. Great talk. Obviously, I believe that we're coming together on the same thing, that ATG matters, right? It's about the timing, the dose.
Yes.
It's not a one-size-fits-all approach for everybody. I don't know very much about Grapholon because we don't have it in the US, but Rick Admiral and Jaap Bolens showed very strongly for thymoglobulin that there's an age effect, right? That the younger patients clear it much, much quicker than the older patients and need, sometimes 6 milligrams per kilo per dose, whereas an older patient might need 1.5 milligrams per kilo per dose to get the same exposure. Do you see that effect in Grapholon? And because I saw you've picked a dose, but is it really a one-size-fits-all dose for all patients, or is there an age effect?
Yeah, we did these measurements in a total of 20 patients, and we tried also to analyze the influence of age, but the number of patients seemed to be too low, so there was no influence of age, but you have much more patients, so I'm sure that there is an influence. Yeah, of course. There are two options to influence the ATG. That is, first the dosage, and second the time between ATG donation and day 0. We have to combine both models.
But I just also want to add that it's not just a question of pharmacokinetic. We need to be very aware that the preparation of Grapholon and thymoglobulin is different. And if you look at the preparation and really the antigens that the two drugs are targeting on the T cells are quite different. So, I mean, ideally, we would need to really have an in vivo comparison and do really analysis of the T cells that get depleted, which T cells are really left over at the time of transplant, are more activated in one case versus the other. So for sure, the data that we are seeing are extremely important because give us so much more knowledge than we had just a little while ago. But there is still these differences in really efficacy that it's not valuable unless we look in depth. We are working very hard for that. It has been 6 years though, so it's through sulfan and Grapholon. Let's see how long it's gonna take.
So I can maybe only add to this. Sorry, my name is here for Melody. Just one maybe remark. Grapholon is not available at the moment. However, if you have an excellent study proposal, it can be imported into the United States for scientific purposes. Yes. We will. I think that we are referring to the proposal. Okay. We'll just, I have already commented on that, and we need some little bit more explanation to this.
Companies here, it's a good opportunity. I think the goal really should be to have a study in which we can really compare the thymoglobulin and the grapholon. And I mean, it can be a study across US and Europe. I mean, why not? That would give really the opportunity of studying. I mean, we have data on both sides, right? It's not that we are offering something that is inferior. I think it's just really understanding if there is something which is superior between the two. So, okay, I mean, there is a caveat here that is, and it's unfortunate that Aryan couldn't come yesterday because of the unfortunate personal issue, but he has a lot of pharmacokinetic data. Because he did, when the forum trial has been run in Europe and grapholon was used, he performed all the pharmacokinetic data in those, I think, were 450 patients. So plus, all the other. So I think that there are data that we can at least, discuss for potentially designing a study.
But forum was only SIDS and bugs, right? I mean, that's a very, very different thing. Like
I agree with you. But again, we have learned from the parachute, which was on PBSCT replete cord, and then we adapted. So it's not going to be ideal, but I think we have data to at least draw some conclusion, understand, and potentially design something which has a rationale.
Yeah. So I would just comment also on the ATG use. In our initial data, our best results, and also when I was at St. Jude, we used the anti-CD3 antibody. And I don't understand in the time of precision medicine, we target every little oncogene with a precision. We use ATG to deplete a T cell. I think this. I would not think that we should now switch too much on ATG for the next 20 years, and rather ask the companies or whoever to give us a specific, maybe monoclonal antibody. It's possible. It's also published and. We know that there is more some company interest, competition interest not to do it. But I think that would be the better way now to jump onto ATG. I think in nowadays, if, let's say, ATG would be a new drug, you would never get a permission or IND approval because you don't know what you have in your hands. What does it recognize? What does it do? Yes, of course. Yeah. That's what we have to look for. I think that's what I wanted just to comment, not to jump now too much the next 20 years on ATG and optimize whether day 5 or day 6, or I think it's not the way that we get much better results.
Thank you, Dr. Lang, for that excellent talk and great discussion. Next up, we have Dr. Susan Hiniker from Stanford University. Dr. Hiniker is Associate Professor of Radiation Oncology, and her clinical focus especially is on the use of radiation in CNS tumors and Hodgkin's disease. But today she's going to talk to us about the role of TBI in a T-depleted haplotransplant. Thank you.
Okay, thank you so much. Thank you to Dr. Bertania and her team for the opportunity to speak, as well as the opportunity to be involved in their exciting work. I think I'm the only radiation oncologist in the room, which is great because then I can say just about whatever, hopefully. But sometimes people surprise me and know like way too much about radiation, then it gets a little dicey. But I'm mostly going to talk about the role of TBI in transplant overall, and I guess how it relates to these depleted haploidentical patients as well. So just quickly, very quickly go through the rationale for TBI, why we use it, our conventional techniques, and then the recent changes we've made here and others are making elsewhere to use a more conformal technique. and then the comparisons between these conventional techniques and VMAT. A brief talk about the outcomes, and then just some conclusions and future directions. So the rationale for TBI, the purpose is really multifold, as everybody knows. The goal is to deliver a homogeneous dose to the entire body, with the goal of eradicating the host bone marrow to allow for donor engraftment, as well as eliminating any residual cancer cells, especially in the sanctuary sites, preventing the host from rejecting donor cells through an immunosuppressive technique, and ideally reducing the risk of a severe graft versus host disease. And we think that marrow and lymph treatment is especially important. I love this trial. It shows TBI is important. Of course, this isn't among haploidentical patients, but as everyone knows better than me, this showed a superior 2-year overall survival in the TBI group versus the chemo alone conditioning regimen, with the benefit seen in the intention to treat population as well as the as treated population, with lower risk of relapse, lower risk of transplant related mortality. And we see that this plateau of relapse is really after 2.5 years in TBI, where it continued in the chemo only group. As a good criticism might be that the TBI group later is going to go on to develop more secondary malignancies, which is likely true, but unlikely enough to jeopardize the survival advantage. So how do we treat TBI? For those of you who've seen it in your departments, the conventional technique is very, I guess I would say, archaic and rudimentary and not very technologically fancy looking. It's been around for many, many decades, and there's 3 conventional techniques typically used. This whole body standing technique, where you need a large vault for that because there needs to be an extended SSD. Some people treat whole body from the lateral sides where patients are seated. And then for these young pediatric patients who need anesthesia, they actually have to be treated on the floor, APPA, which is difficult, especially flipping them over when they're under anesthesia. Here at Stanford, we typically use the standing technique. We use a patient-specific compensator used to keep the dose homogeneous, and that's constructed for each patient. We use lung blocks to block 50% of the dose to the lungs, and then electron chest wall boost to treat the marrow and the ribs under the lung blocks. Others, as I said, do it other ways. There's different ways where lateral beams can be used or a sweeping beam on the floor. Dose rate has been a concern over time, especially with potential effects on the lungs. And most people make some attempt to reduce lung dose with some form of blocking. For these myeloablative regimens, we're typically giving around 12 gray, 12 to 13 gray, most commonly 12 gray and 6 fractions, along with chemotherapy. As we know, this is quite a toxic treatment, or can be, and associated with significant transplant-related mortality, especially among patients with comorbidities. Here at Stanford, we also treat what seems like a pretty large number of patients with reduced intensity conditioning transplants for non-malignant diseases, which is often 2 gray in a single fraction, 2 to 4 gray. And this data on the right shows different dose fractionation schemes practiced in COG member institutions. So you see there's this variety, but many using the 2 gray and 1 or the 12 gray and 6 regimens. So this is a tough technique though, because it's hard for patients who can't stand for what may take 10 to 15 minutes for a treatment. There's a lot of dosimetric uncertainty. You don't really know what the organs are getting. It's difficult to construct the compensators. It's a very error-prone process in terms of measurements, manual entry of all the measurements. You need this extra large vault, and it's difficult if you need to treat any larger child on the floor who needs anesthesia. So there's a lot of issues with it. And we know all about toxicity that you get with conventional TBI, both short and long term. So interestingly, as people have started to think how we can refine this technique to improve it, there was an analysis of patients treated with TBI on COG trials, and showed from this compilation of data worse overall survival among patients with a mean lung dose of more than 8 gray. And also an analysis showing that the beam arrangement matters for that. So with patients treated with APPA, where you really can create something that blocks the lungs, had a lower dose, mean lung dose, than the patients treated with the lateral beams, where arms are used as natural lung blocks. And so at least food for thought that the technique of radiation is important for these transplant patients who are receiving so many complicated therapies and have a lot going on, but that lung dose is important. And in further thinking about this, the COG performed a study among radiation oncologists of different TBI techniques and surveyed physicians and physicists and asked, do you want to introduce these more fancier techniques when by VMAT and TOMO, we'll go on to that in a minute, but it's essentially a much more modern technique of radiation therapy where you scan the patient, they're treated supine. It's much more like our radiation therapy techniques for other tumors where you can actually measure the dose that different organs are getting and provides a lot more flexibility in terms of boosting or blocking or reducing dose to certain areas. But at that time, which was back a couple years ago, there were only 7 institutions in the US that were using VMAT TBI. So this intensity modulated TBI, which is basically a basket term that covers VMAT TBI, helical tomotherapy, these are all different techniques of doing a similar thing, is essentially using arc therapy with the patient lying down and multiple beams going around the patient to deliver the dose, and is happening mostly at these centers listed here, but others are more and more picking it up as years go on. And at Stanford, we started this back in October 2019, and we've treated probably 120 or 140 patients by now. And you can see what kind of plans you can get. So this is much more typical of kind of modern radiation therapy where we can see the dose going to what part of the body. You can actually measure what the lung dose is, the kidney dose, and it gives you much more control over the ability to give higher or lower doses to certain organs or areas. Just very briefly on the technical aspects. So the patient undergoes simulation in this whole body bag that you see on the bottom picture with arms close to the side and their knee and foot fix. And then if the patient is too tall to fit through the scanner, you have to use this thing called a spinning mani to flip the patient so you're scanning them head first and then foot first. And then we can contour all the organs and specify what we want each organ to get. So for the myeloablative regimen, typically based on others' data, we spared the lungs to about 50%, kidneys they get about 75% of the dose. We can spare the lenses, although sometimes we do and sometimes we don't. Reduced intensity conditioning has been, I think, even more exciting when we're treating non-malignant diseases and talk to the patient's stem cell oncologist about what they believe it's safe to spare. But in those situations where we're not worried about cancer cells, being potentially in these organs, we spare a lot of things, including lungs, kidney, lenses, then brain, because the brain, often doesn't really need that dose, even though it's low. I'd rather not have it. Thyroid, ovaries, testes. And then these are different dose constraints that we use. So currently on the HSCT 2031 protocol, there has been over the past several months a lot of work on incorporating the ability of centers to use VMAT TBI or IMRT-based TBI as a technique on trial, which was at first a subject of debate because it hadn't really been tested in the COG setting. And so people didn't feel that it was necessarily, was it safe to use? But then if you look at the plans, it's actually a lot better than what has been used. So eventually, I think it all worked out, and it's going to be some pre-treatment central review, but it's an allowed technique. So this is sort of how a dose distribution would look and the requirements that we picked for the plan. So you look at your PTV, which is the whole body, and you want 90% of that to get 100% of the dose. For this particular group of patients that we described, the mean dose of the lungs was getting 42%. You can spare the ovaries and the gonads if you want to. We did spare the brain for these patients. And you can get these really beautiful looking plans that give you a lot more information too about what's actually getting treated. Just to give you a few kind of special cases that we've done here. And I think the challenge with having this technology is knowing really when it's safe to use, and because we can spare and we can boost these things, is it okay? Because now we can, we really couldn't before. So this was a patient who had AML in relapse and was initially getting a chemo-only conditioning regimen, and then started progressing in her skin during her conditioning regimen. And so we were requested to add at least a low dose of TBI. So basically, we treated 2 gray to the whole body, 4 gray to the skin lesions, and then with a 6 gray boost to this larger lesion on her buttock. And she actually did quite well from, her leukemia cleared. She had other issues, but the treatment seemed to work. We had this other patient who had, he's an 18-year-old boy with ALL, and he had such bad liver dysfunction. I think he was evaluated for liver transplant prior to going for stem cell transplant, which he didn't need, but that's how bad his liver function was. And so it was a concern of, can he really handle this conditioning regimen? So after a lot of discussion and back and forth, we elected to spare the liver to about half the dose, which we felt, we could do, and we felt that was probably in his best interests. His stem cell physician felt that he was in a very deep remission, and he did well. And then there's all these patients who have had prior radiation for a certain reason, and you would like to be able to avoid it in some cases, although, 12 gray is pretty low, but this child had 60 gray to the brain for like an embryonal sarcoma before TBI. And because of that, and she didn't have CNS involvement of disease, we felt that it was better to spare that area since it had already gotten 60 gray. So just different abilities that we had before. We could kind of try to boost and block things before with the 2D technique, but I'd say it was much less precise for sure. This was an initial report of our first 35 patients treated and just the different doses that they got to their body, to their various organs. And then this was a short report just comparing 10 patients who were treated with VMAT TBI, and then creating plans for 2D TBI, the standard TBI, of how that would look if they were just treated with the conventional technique. And it's interesting, we found actually worse coverage even with the older technique, much worse mean lung dose as we would expect, and then just the ability to spare these other organs when we wanted to. This is a DVH, which we look at a lot, which just essentially shows dose to each of these organs and comparing the two plans. And I'll summarize it by saying that the VMAT is better. And then this was a little report we wrote on just how you can spare the gonads, 2D versus VMAT. And we're still pretty much just doing this for the non-malignant patients. I don't think we have evidence to suggest you can do that in a myeloablative transplant, but even 2 gray may be important, and so sparing that we think can be helpful. So how do these patients do overall, and are we potentially causing any problems, by sort of treating the body more conformally than we used to? I think this was among our first 38 patients treated, and they seemed to do very well. This was kind of early time point, I think 18 months or so, mean follow-up, but did well with overall survival and relapse-free survival, very good. This is a mixed bag of patients, so some of these were treated with myeloablative regimens, and some of them were treated with single fraction regimens, so a mixture of diagnoses. We saw the most severe acute toxicity with mucositis, but overall, fairly well tolerated. And this just talks about what we were able to spare each of the organs to. We're doing a larger analysis now of looking at VMAT versus 2D TBI in pediatric and adult patients, which is ongoing. But essentially, VMAT, we think, in terms of acute toxicity, looks slightly less toxic, although for any grade 3 toxicity, although some have reported that mucositis is worse, and it may be. And these are just other techniques in the literature, including in other countries, that are working on similar things. So there's certainly things to think about with this technique. And one thing when we present our experience to other centers who are getting this started, sometimes people think about dose rate and how much can that affect problems with lung toxicity, because usually with the 2D treatment, the dose rate's a lot slower. And with this technique, the dose is going a lot more quickly through the lungs, although you can slow it down, which we do, makes the treatment take longer, but we do out of an abundance of caution. Some centers don't think that's important, and they don't, so that's kind of unclear if that's important yet. This was a patient from NYU who had a grade 5 pneumonitis with what would be considered a very good mean lung dose. So all of these, I think, are just food for thought. You know, she had other problems like her age and her BMI. But that's one thing that is when we're thinking about potential dose rate, maybe that was related. Hard to know. So on study, this, as I said, allows VMAT TBI with a pretreatment central review. It has some strongly recommended dosimetric plan objectives, and these will be reviewed beforehand so centers can start doing VMAT TBI, but have the plans reviewed before they can actually treat patients. And it'll be interesting because I think it's now an exploratory aim of the study to look at patients who are treated with 2D versus those treated with these IMRT-based techniques and see if there's differences that we can find in toxicity. Then this dose rate issue, just something that we talk about that we aren't sure if it matters, but some centers, that's the other thing about TBI, as you all know, some centers do it different ways. It's a labor-intensive process and people are doing different things. So maybe dose rate matters, but we don't know yet. I think in the future, and when we're doing this work, one thing that's difficult as radiation oncologists is to really define and attribute the toxicities well. These patients are, of course, sick and they're getting many therapies, and it can be hard to tell exactly what's from what. Defining the pulmonary toxicity also in the literature, I think maybe has not always been attributed to radiation in ways that it perhaps should have been. So this idiopathic pneumonia syndrome, and the dose rate question being important. Also this mucositis issue, and if you can get more of that with these conformal techniques is important to think about. There's a data from Moffitt where they had 2 grade 5 toxicities that they attributed to mucositis, which is hard to know, again, if that's how much radiation related that is. But something we can probably do better is have a little bit more involvement in our patient follow-up, at least initially, as radiation oncologists, because those are the things that we're mostly thinking about is, you know, what could radiation have done here in terms of causing the side effects and maybe helpful for the data collection in the future. So in conclusion, I think there's a lot of promise to VMAT TBI. We can do a lot of amazing things we really couldn't do well before, including sparing organs, performing integrated boosts where there's areas of disease. We finally really know what we're giving in terms of dose calculation. Patients are lying down, and another important thing is that you don't need a huge vault to treat these patients. They can be treated in a normal radiation vault. Relatively low rates of acute side effects, but that's still being kind of assessed. I think a major thing that we're thinking about now is, now that we can do these things, what should we do and what's safe to spare, both in the malignant and non-malignant setting, and these myeloablative and non-myeloablative, like what's okay to spare, or where do we need to boost, so that we're sure not to compromise outcomes. And that we certainly need longer term follow-up to evaluate, and multi-institutional studies will be important, especially with the COG incorporating this now. And these are all the people who have worked on it, especially our physicist Natalia, who's done really most of the work on this. And that is it. I'd be happy to take any questions.
So I wonder whether we have now consensus as to what the real expected effects of 2 gray and 4 gray are, whether with 2D or VMAT. And secondly, I wanted to ask you whether VMAT has an effect on the effect of TBI in preventing rejection when you are using it at 2 gray only.
Yeah, it's a good question. It's a very good question. So I think that in terms of 2D, 2 gray or 4 gray, and how important is that? You know, it's a very low dose. So is that really going to cause much toxicity by itself? I think it's unclear, especially when you look at probably the most sensitive organ being reproductive organs. There's some sort of mixed data that suggests that 2 gray in some patients, plus of course significant systemic therapy, may have an impact on fertility. It's hard to know. I usually think of it as, you know, more like, well, in these patients who don't even have a cancer and we don't need to be treating those areas. You know, 2 gray, if you think of that as like thousands of CT scans, and we try to minimize things like that in patients. So why not minimize it if we can, unless we're causing any problems with, of course, the transplant itself. I don't think we've seen any indication of that yet, but I think it's really important for us to be doing it, certainly in conjunction with the stem cell oncologists who have a lot more insight into what areas are important to cover, would be my thought.
But in relation to counseling patients in the non-malignant setting, are you able to give some indication as to what the risks of both infertility and secondary malignancies are? And does that get changed with using VMAT?
For 2 gray or for anything?
With 2 gray or 4 gray?
2 gray or 4 gray. So I think that for malignancies, I would say that
For non-malignant situations.
for secondary malignancies or just?
Yeah, secondary malignancies in non-malignant cases.
Yeah, so I would say that maybe what we say about protons, similarly, that theoretically with VMAT, you know, in a large number of patients, if you compared it to 2D, you would probably see a small difference in number of secondary malignancies just because of area of the body getting dose of radiation is smaller, but that effect is probably quite small. I think these effects are probably small, but since we can spare it if we're not deleteriously affecting things, I think it's ideally good to do. Go ahead.
And in relation to rejection, does it have an impact?
We haven't seen that yet in our early data, and it's something we always talk to our stem cell team about if they're, you know, have any concerns based on the condition itself. Then we certainly, it would be something like that we feel that we spare if that's really, you know, felt to be appropriate. But again, the toxicity not being that great, I think that we don't if there's any concern.
It's interesting in the sickle population. We have always thought that the people who are getting greater rejection risk is because they come from settings of low and middle income countries where there may be poor provision of red cell units and they don't leukodeplete and there is alloimmunization and so on. But the other characteristic is that they don't have VMAT, whereas the centers who seem to be doing well with the protocol do have VMAT. And I just wonder how much then it is due to the TBI provision rather than the supportive care of their blood products. But I don't think we can answer that, can we?
Yeah, well, sorry, I missed the first part of that. What can you repeat that?
Well, in the PTCI setting of haploidentical transplantation in sickle cell disease, where we use 2 gray of TBI, it hasn't always been well replicated in low middle income countries.
Oh, interesting. Okay.
Because of rejection risk, which often we have thought it was due to alloimmunization and the provision of blood. But the other characteristic is that those centers don't have VMAT.
Interesting. Yeah, and I don't know, you probably know more than I do about how many of the centers in the non-low to middle income centers did have VMAT for that, because it still was relatively rare even as of a few years ago. But that's really interesting to think about. Thank you.
Thanks, Dr. Hiniker. Our last but certainly not least speaker for the day is Dr. Dvorak. Dr. Dvorak is the Chief of Pediatric Allergy, Immunology and Transplant at UCSF, and his research focuses on ways to lower the incidence of relapse in patients undergoing transplant for childhood leukemia and minimizing transplant complications to improve outcomes.
Hi, everyone. So I was originally going to talk about ATG-PK, but Mike said he wanted to do that. So I switched it up, and this doesn't really have a ton to do with leukemia. Instead, this is sort of a look at some of the common problems that we run into with alpha beta T cell depleted transplant and some little process optimization tweaks that we've made that I think have improved our outcomes. And these are nothing super fancy. This is all stuff that you could take home and do tomorrow if you wanted. So obviously, you know, this is a great platform. That's why we're all here. We believe in alpha beta T cell depleted transplant in children and young adults at least. But no one out there has shown 100% survival for anything yet, so we can always optimize the process a little bit more. Oop, what did I just do? I'll do this. Okay. So I'm going to talk a little bit about engraftment syndrome and its role in subsequent graft versus host disease and our use of tocilizumab for prevention of that. We haven't heard a lot about engraftment syndrome today, so maybe this is a UCSF specific thing, but it's something that we've seen quite commonly. And then I'm going to spend most of the talk talking about graft rejection and what are the risks, because we have had that come up quite a few times in the last 2 days. Specifically the conditioning backbone, role of early CMV reactivation, and then fludarabine optimization. So first, engraftment syndrome. So in mid-2020, we noted that about 2/3 of the patients at UCSF who engrafted required steroids, usually hydrocortisone, for treatment of engraftment syndrome. And these were really high fevers around day 10 to 12, sometimes with a little bit of low-level oxygen requirement, usually without a rash. And the first couple times we saw it, we really didn't know what was going on when we were doing every PCR under the books and really quite puzzled. And it wasn't until I called Mike and said, "Mike, what the heck's going on?" And he said, "I don't know. Let's call Wing Liang." All right, so maybe I didn't read the protocol well enough. But we later realized that there was a strong association with patients who developed engraftment syndrome and went on to develop GVH. So as of June 2020, when we looked at this, you can see that we had quite impressive amounts of graft versus host disease in those with preceding engraftment syndrome. Whereas in the ones that didn't, our GVHD rates looked pretty good. And when we looked at that and we thought to ourselves, heck, this is great. If we could accomplish this in everybody, we'd be really stoked. This would be like, happy trails. So what is engraftment syndrome? Well, it's obviously a cytokine storm phenomenon. Cytokines drive a graft versus host disease via activation of T cells. And if we blocked engraftment syndrome, could we prevent GVH? And if so, which cytokine to target? Because it's obviously a multi-cytokine factor going on here. So the Cincinnati group, led by Pooja Khandelwal, had published a nice paper where they looked at different cytokines involved in engraftment syndrome. And the first ones that came up were IL-12, which we don't have a good target for, but IL-6 and IL-1 beta. So we were kind of interested in the in IL-6 for this. And around the same time we were struggling with this, Sandhya Kharbanda, who's our medical director at UCSF, had gone to this talk at TCT in 2020, where the adults at Sloan Kettering were seeing a lot of engraftment syndrome in their double cord blood transplants. And they decided to introduce tocilizumab on day -1 at a dose of 8 milligrams per kilo. And what they saw was a nice drop in their engraftment syndrome without really much effect on grade 2 to 4 GVH, but what looked like a decent drop in grade 3 to 4. And that makes a lot of sense to me, right? We don't want to see grade 3 to 4 GVH, but a little grade 2 GVH might be okay for a leukemia patient. So Suhee Cho, who's sitting right over there, was a fellow with us last year. He's now attending at Utah with Mike, had put this together for a TCT abstract last year. And I've updated it since then. We did something very similar. We added tocilizumab with a higher dose to the younger kids because they clear it faster. And we had quite shockingly similar results to the adult Sloan Kettering patients, where our engraftment syndrome went from almost 2/3 of patients down to a little over 20%, without really any significant effect on grade 2 to 4 GVH. Maybe if you squint hard, a little bit of drop in grade 3 to 4, and no real effect on chronic graft versus host disease. So we were a little surprised by this, that although we had cut down our engraftment syndrome by almost 2/3, we really didn't make a huge impact on our GVHD rate. So my conclusion was that solo IL-6 blockade is really insufficient to fully address this issue. I suspect that IL-1 beta is probably involved here, though I don't have actual cytokine levels to back that up. If anyone has cytokine levels and wants to share them with me, I'd love to chat with you during the break. So you might be sitting there asking yourself, well, Chris, is prevention of engraftment syndrome alone a sufficient reason to give TOSI to these patients? And I would say, well, maybe not. But let's put a pin in that because I want to come back to it at the end of the talk. So let's switch to rejection, because I think this is a common problem for everybody. Everyone out there has mentioned it in their talks. And Mike has shown this slide already. When we did the ONC 1401 paper and showed these really, really nice outcomes of haploid transplant, we chose disease-free survival for a reason, because it didn't incorporate the event of rejection. So we kind of snuck in what looks like better results. And in fact, there were 8% of patients had rejection on this study, 2 AMLs, 1 MDS, 1 ALL, all of whom had gotten the Flumel-Thio approach. And they were fairly high-risk patients. Some of them hadn't had chemo recently, and they're all successfully engrafted, so we sort of hand-waved them away in the paper. But this is a common problem, as we've heard. Dr. Murley has already talked about this, and he's published a lot of nice papers recently showing problems with rejection. In acute leukemia, at least in Italy, it's not as common, but in Italy they use a lot of TBI, and as we'll hear about, TBI is really good at getting grafts in. And so and I couldn't quite tell from the paper, but if all of the 5 rejections happen in the non-TBI group, then it's about 10% or so, which is kind of similar to what we saw. 14% for MDS, 3 of whom hadn't had pre-transplant chemo, and in the non-malignants, quite a bit more. So looking at just UCSF specific patients, this is first transplant only. We've done, at the time I did this analysis, 105 first transplants, and we've had an almost 9% rejection rate. And as somebody mentioned earlier, I can't remember who it was now, these all are primary immunologic rejections happening right around the time you would expect counts to come in. You get these high fevers, a rapid spike in the LDH, and sometimes a transient rise in the absolute lymphocyte count that then goes away, and you've got an aplastic state. And we've seen it after every type of donor for the most part, maybe a little more common in moms with mom donors, but not statistically significant. And then we did manage to re-engraft 7 of the 9 with the second transplant. 2 of them rejected the second. We ended up getting a third transplant into them, and those were long-term survivors. And so, at the end of the day, the outcomes are not too bad for these patients, 8 out of the 9 long-term survivors. But this was hairy times. I mean, these patients were sick. We were stressed, having to recondition them. So we really would try to figure out how to avoid this. I do want to point out we had much better rates of getting different donors in than getting the same donor in. So the one thing that we've done now is if we were to see rejection again, we will always switch our donors. So I've already mentioned that TBI is good at getting the grafts in. This is going back to the multi-center data set that Mike presented yesterday, which I think is the biggest US experience of 163 patients. 9% rejection, but you can see TBI only 1 rejection there, right? So TBI is good at not only making space, but killing lymphocytes, whereas busulfan is as we know from the autologous gene therapy experience, is a very pure myeloablator. It doesn't really prevent rejection at all, at least immunologic rejection. And melphalan doesn't appear to either. The other, I think, big factor here was absolute lymphocyte count on its own, just over 1,200, was a very, very, very strong predictor of who was at risk for rejection. So you could say, well, TBI is great. Let's just use it for everybody. But if you know me, you know that I hate TBI. No offense to our previous speaker, I don't know where she went. And my goal at UCSF is to eliminate TBI from all of our transplants. And it's because we know after paper after paper after paper that it is the major risk factor for late effects. And I'll try to convince you that, at least in the US, the European data is a little different, that with this very strong graft versus leukemia effect that you get with alpha-beta T-cell depleted haplos, you don't need it for disease control in most patients. So here's what I mean by that. This is the same multi-center data set that Mike showed yesterday, 163 patients. And you can see in the patients with ALL, disease-free survival was identical for melphalan and TBI. Now busulfan, there weren't a lot of patients here, but busulfan really didn't look good. So when you think about the Forum study, which of course was randomized between TBI and busulfan or trio, didn't have melphalan in there, but melphalan seems to work okay, at least in the haplo setting. But it's really about the MRD positive patients. So in the MRD negative patients, melphalan looks great. TBI a little less good, and that's not because it has more relapse, that's because it's killing patients. And busulfan is by far the worst. But it's in the MRD positive patients where MEL is not so good, right? Look at this difference between what MEL does in MRD negative and MRD positive. So MEL is not very good at clearing low-level disease, whereas TBI, there's really actually not a huge difference here between the MRD negatives and MRD positives. TBI is good at mopping up low-level residual disease, buying you time for the graft versus leukemia effect to kick in. So at UCSF, we really have reserved TBI only for MRD positive patients, which nowadays with CAR T cells, are good at getting doing a really good job getting patients to deep sequence, high-res deep sequencing MRD negativity. It's about 8% of our patients need TBI. So how do we ensure engraftment in those not getting TBI? So again, this is the 105 patients getting first transplant with alpha-beta T-cell depleted transplant or alpha-beta T-cell depletion at UCSF. And I looked at all the factors associated with the rejection. And not significant was age, sex, race, ethnicity, donor, CMV serostatus, CD34 dose, alpha-beta dose. Those were, I thought, really surprising. I thought for sure I could find a CD34 dose that was important or an alpha-beta dose that was important. I thought for sure ATG exposure would be important, and I couldn't find a cutoff that made a difference, even though it makes a lot of sense mechanistically. The only things that were significant were patients with non-malignant diseases, which at UCSF is primarily inborn errors of immunity, so SCID, some CGDs, and ALLs have less rejection than the AML, MDS's, other malignants. It's a pretty borderline p-value. I think this is really a reflection of the fact that these patients have a little weaker underlying functional immunity, and we did use some TBI in our ALL patients. And the only thing that was really, really strongly associated was, again, the absolute lymphocyte count. Just that alone was incredibly predictive at who was at risk for rejection in our center. So, but there's got to be other things going on, right? What can we do about this? So one of the things that I noted really early on was that a lot of the patients who rejected had early CMV reactivation. I'm talking prior to day 0, day +1, super early. And if you're a transplanter, you know that there's the long-standing lore that CMV reactivation can kick your graft out. So I developed a hypothesis that maybe CMV was important here. CMV is very common. This is our UCSF data set. And you can see in the R positive, D positive patients, we have over 60% reactivation rate. So pretty common. Obviously none in the R negative, D negatives, and a little bit in when you transfer a positive donor into a negative recipient. In the multi-center data set that Mike showed you yesterday, no patient was reported to die of CMV as their cause of death. However, the non-relapse mortality was strongly associated with their CMV serostatus, right? This was on multivariate, it was the strongest predictor of non-relapse mortality, this D negative into an R positive patient. So clearly there's something going on behind the scenes with CMV reactivation, its impacts on the immune system, as Alicia talked about yesterday. And so I had this hypothesis that early CMV infection promotes rejection, and whether that's activation of residual host T cells or NK cells from the data that Peter and Rupert, I think, have presented, sounds like it's more T cells than it is NK cells. And we know that lymphocytes secrete cytokines like interferon gamma that augment the host versus graft response. Dr. Murley already showed this paper earlier today with these febrile rejections being associated with spikes in CXCL9. So to make a long story short, this is our UCSF rejection rates based on CMV reactivation. And so if you reactivated CMV before day 14, 5 out of 16 patients, over 35% of patients rejected. Whereas if they had late CMV infection after day 14, we didn't have any. Now, obviously, CMV is not making the whole story. We still had some rejections in the patients who didn't ever reactivate CMV. But I think this is a pretty strong difference here. And so clearly there's something going on. And although I do believe in distal ATG dosing, giving it day -12, we may even need to go a little further away from the transplant. I think this produces a prolonged period when their counts are low and they're at risk for early CMV reactivation. So if prophylaxis is to fix this, you need to start it really, really early. But CMV might be good for you too, right? So how long do you continue it for? Because it's a double-edged sword in patients with cancer, as Alicia already talked about. Non-relapse mortality is not the major reason why patients die after alpha-beta T-cell depleted transplants. It's relapse. And there's lots and lots of papers showing that CMV reactivation or even CMV seropositive status decreases relapse rates. So if we're too aggressive with our prophylaxis, we may actually get a backfire. And again, as I already showed, or Mike showed yesterday, the relapses are primarily occurring in the patients who are MRD positive. So this is the strategy that we've developed at UCSF, doing what I call risk-adapted prophylaxis. So in the R-negative, D-positive patients, their risk is pretty low. They get letermovir starting on day 0. For the non-malignant patients, we continue it till T-cell reconstitution because they don't benefit from CMV as far as we can tell. For the malignant patients who are MRD negative, we do the traditional 100 days as adapted from the MARDI trial. But for the MRD positive patients where we really worry that they're at risk for relapse, we just want to get the graft in. So we get the graft in and then we stop it. For the positive D positives, here we stole the idea from Filippo Milano at the Hutch, who was having the same problem with cord blood transplants and started doing ganciclovir. So we do that on admit till day -1, and then we switch to the same letermovir approach. And then in the R positive D negatives, these are the patients that all died, or not all of them, but had huge rates of non-relapse mortality. Here we just said, we don't want 40% NRM. If we're going to try to avoid these donors if we can, but if we have to use them, let's just continue the letermovir until they're reconstituted. So this is still early days. It's a little tough to say for sure that this is the right approach, but I think it makes a lot of mechanistic sense to try to walk that fine line between getting the grafts in and making sure patients don't relapse. So I do have some data on whether it works. So here is our use of prophylaxis and CMV infection. So here's now just host CMV serostatus. So it's CMV positive patients. Their CMV infection rates, if they don't get prophylaxis, almost 80% by a year post-transplant. With prophylaxis, it doesn't completely get rid of CMV by any means. People definitely break through letermovir, but it delays it quite a bit. And in the CMV negative patients, where again, they only get CMV if they get it from the donor, we knocked it down to 0. And with our rejection, I think also bears out that there's some benefit here with the CMV positive patients getting no prophylaxis, over 30% rejection, down to about 10% or maybe a little lower. And then in the CMV negative patients, it went down to 0. So switching gears, fludarabine. I've already mentioned fludarabine a couple times. And I think I spent a lot of time thinking about fludarabine because I am good friends with Janelle Long-Boyle, who's one of the world's experts in the PK of this drug. And I think a lot of transplanters maybe don't think about flu as much as we do at UCSF because of Janelle. In the old days when I was a fellow with Rajni, we were all BuSci for everybody, and BuSci sucked, right? It was super toxic. And so we got BuFlu and we're like, this is great, we're done. And we sort of, stopped thinking about it a little bit. But we can do better with fludarabine. So when Mike and Wing wrote the ONC1401 study in 2014, hence the name, they used 5 doses of fludarabine, 40 milligrams per meter squared. The problem is that in 2017, Janelle published a paper showing that this is not the right way to give fludarabine. And the reason is, I'll show you on a subsequent slide, that F-ARA-A, which is the active metabolite, is intracellularly saturated after 4 days. So that 5th dose does nothing for your patient. It's a complete waste. I mean, it goes into their bloodstream, but it does not get into their cells. And then in our original paper in 2017, we had identified a cumulative exposure around 16 to 18 that we thought was best in the SIBs and MUDs. Yabolins later published a really, really nice study with even more patients showing that a cumulative exposure of 20 results in the best outcome. So we've since switched to that. And what you can see here is that the patients who had optimal exposure of fludarabine have much better event-free survival than patients either above optimal exposure, who die of toxicity, or have below optimal exposure, who have either rejection or relapse. So why is this so complicated? Because you think of it as it should be pretty easy, but in fact, this is a complicated drug. So, fludarabine is a analog of normal adenine and has to be dephosphorylated in the bloodstream by these 5' nucleosidases that are found in erythrocytes and endothelial cells to F-ARA-A. F-ARA-A has to be actively transported into the cell, where it undergoes additional metabolic changes before becoming F-ARA-ATP, which is an analog of normal ATP, and then gets incorporated into DNA RNA synthesis and results in apoptosis of the cells. So the problem is that, again, that it has to be actively transported in. So here's your plasma concentrations after each dose of fludarabine. Goes up, goes down, up, down, up, down, up, down, up, down. So as long as you have normal renal function, your peaks and troughs are incredibly consistent across subsequent doses. But here's the intracellular, and this is what you need. You get a peak, goes down, up, down, but as you get further and further out, and then with the 5th dose here, the peaks are lower than the troughs after the 1st dose. So you're really saturating the system. And I think, Janelle would be so thrilled if you guys came out of this talk and vowed to change all of your regimens away from 5 days of fludarabine, because it really, I think, it doesn't make any sense pharmacokinetically. So the original model was pretty good. This is a paper we published 2 years ago now, where we incorporated model-based dosing at UCSF to try to hit a target somewhere between 16 to 20. And you can see the original model did really, really good at doing that. At the same time, we had some partner institutions who were doing traditional BSA-based dosing, and they sent us levels to see how they were doing. And you can see, well, many of their patients are okay. There's this much broader range of exposure when you do body surface area-based dosing. And there were still some tails with our original model, but we've since optimized the model, which has really cleaned this up. And the outliers were primarily infants and the obese. So looking at our UCSF data set, in patients who use fludarabine-based conditioning without TBI, because again, TBI gets grafts in great, overall rejection was 9.5%. But here it is based on traditional milligrams per meter squared dosing versus model-based dosing, hitting a cumulative AUC of 20. You can see a significant decrease there from 18% to 2%. And the one patient who rejected had a cryopreserved graft in the early days of the COVID pandemic, when we weren't sure if we could get the donor collected because of all the craziness that was going on in like March or April of 2020. So this isn't super fancy, right? Anybody, this is not like confidential information. This is a published model. Now, there's companies that you can use, like InsideRx, who will do this for you. But if you have a really good programmer, you could just program this to do this yourself. This is a prodrug. It needs active transport. Don't give 5 doses. The standard milligram per meter squared dosing does work for most of your patients, but the very young, the obese, the renal insufficiency, you can get all kinds of different exposures. There's actually differences in boys versus girls in terms of clearance of fludarabine. So you can really dial in a very specific exposure. And unlike busulfan, where you have to get levels in real time and make real time adjustments, it doesn't change that much. So you can actually just do this at the very beginning, put in your dose, and you're done with it. And hopefully I've convinced you that this helps decrease rejection. So I promised I'd come back to tocilizumab. There is data in kidney transplants that IL-6 produced by macrophages and dendritic cells stimulates acute T-cell mediated rejection. So I asked the same question. You know, we've had 88 patients, first transplants, treated at UCSF with non-TBI based regimens, overall rejection around 10%. And they all had these high fevers. So, and we all know from CAR T cells that IL-6 is associated with fevers. So I thought to myself, well, maybe there's a difference here. And sure enough, a quite significant difference in our rejection rates between patients who did or did not receive tocilizumab on day -1. Now, I do want to make a very, very important caveat. There is near perfect accord between those who received toci and those who got fludarabine model-based dosing, because I made both switches at the same time. So I can't really tell you which one worked. But this is how we've evolved the approach at UCSF. Here's the original ONC1401 regimen with kind of traditional dosing of everything by mg per kilo or mg per meter squared. And nowadays, Mike already talked about rabbit ATG being personalized for a dose. The fludarabine we've condensed into 4 days and now target a exposure. We're still doing thiotepa and melphalan the old-fashioned way, though we're working to develop PK, PD based exposures for those. We've added the tocilizumab on day -1. We've moved the Ritux and are giving just 100 milligrams per meter squared like the Russians do, and then added the ganciclovir and letermovir as needed up top. So you might ask yourself, what worked, Chris? And the answer is I don't really know, but something worked. So prior to June 2020, we had huge rates of rejection at UCSF, 9 out of the first 37 patients we did. After June 2020, the last 51 patients have all successfully engrafted. Was it the aggressive CMV prophylaxis? Maybe. Was it model-based dosing of fludarabine? Maybe. Was it the day -1 toci? Maybe. Was it something else that I haven't even measured? Maybe. Maybe it's a little bit of everything, because rejection's a complicated phenomenon. And there's probably other ideas out there, right? There's emapalumab, even though that's ridiculously expensive. There's some waves of giving fludarabine a couple times prior to admission, which could work. But I think these are all little tricks that you could do that will help bring your rejection rates down. So in conclusion, the patients at risk for rejection are, again, the ones with high lymphocyte counts greater than 1,200 that aren't getting TBI. I think we can prevent it with some combination of different approaches. I think thiotepa model-based dosing, when that is available later this year, may also help. Engraftment syndrome is common, at least in our patients, is associated with subsequent GVH. The toci helps a little bit, maybe drops our grade 3 to 4 GVH a little bit, but we're going to need to do more work, probably with IL-1 beta, to really completely eliminate that. So obviously ONC1401 was led by Mike Pulsifer, and I want to thank everybody who sent in data for the multi-center data set. And of course, Janelle Long-Boyle has led all of our PK/PD work at UCSF. Thank you.
So, Chris, one question. Sorry about that. One question and quick clarification. So I took PK because I couldn't have done this talk. You know, it was the only thing left. So Chris, this is really great with the patients who have malignancies that are a little easier to get grafts in. But what can we do in patients with HLH?
Yeah, we haven't done very many
or
HLHs
CGD.
with haplos. We've done a handful of CGDs, not maybe 3 or 4. They've all engrafted. Small numbers. We'll have to see.
MDS?
Well, we've done again a handful since June 2020. They've all engrafted. Okay. Prior to June 2020, we had a lot of rejections with them.
Yeah. Okay.
So, Chris, back to your elevated ALC.
Yeah.
So the question is, with all those changes, has the elevated ALC still remained a risk factor, or have you negated the impact of the elevated ALC with the other changes?
Well, it'd be tough to look. Well, so you're asking if I looked at just the patients after June 2020. Well, because then there's no rejection, so it'd be tough to tell a difference at that point. So I feel like we've.
Well, the question is, are there people who had the elevated ALC after June of 20?
Well, 1,200 is not that high, so.
But as I understand the way the algorithm is set up, there's a cap where you don't increase the ATG dose anymore. So my question to Ben is that if it's still held up that an elevated ALC was a risk factor with all the other changes, you might then not want to cap the ATG dose based upon the ALC, but continue to extend.
we don't cap it at UC.
Oh, you don't?
Yeah, I mean, so there's two ways of doing ATG. So there's the way we did it for the trial for or HSCT 2031, which was we created a nomogram. Or I don't know if you created it or Yop created it, but that's a pretty good nomogram that generally gets you into the goal range. Or you could actually use the actual system like Inside RX, and you could dial in a very, very specific exposure. And so we use Inside RX and just give whatever it tells us to give, whether that's 5 mg per kilo, 6 milligrams per kilo. I mean, again, those are the babies. The older kids, they get much less.
But it would still be interesting to see whether that association is still there given all the other changes.
Yeah.
Susan, you go first.
Hello, that was very interesting. Very interesting. So I had a couple of questions. One question was, so do you think your main issue with the Forum trial is that they didn't use melphalan, or do you think it's a different kind of transplant?
I think the problem with the Forum trial is that they were still trying to use SIBs and MUDs. We don't use SIBs and MUDs for leukemia anymore because I think the GVL effect is too weak. I have fully drunk the Kool-Aid. Alpha beta T cell depleted haplos for everybody.
Okay. And is melphalan, like, it's shown to be better than those systemic therapies that they used?
Well, at least in the alpha beta T cell. So we don't have any trio data in the US, obviously, so I can't speak for that. But in the US, busulfan and alpha beta T cell depleted haplos don't seem to work very well. And you showed in Rome that busulfan didn't do as well as TBI. So for whatever reason, Bu is not a great drug with alpha beta. Mel seems to work quite well as long as you're in good remission.
And then the other question was, if this is like kind of, I guess, a sort of de-escalation in terms of toxicity, at least, therapy approach, if patients relapse, do you do TBI-based regimens, try to do a second transplant?
We have, yeah, and actually they do tolerate it reasonably well because the first transplant was so gentle comparatively. Obviously, if you tried to do it after busulfan, it would be a lot harder.
Okay.
But we're trying to get away from doing second transplants for treatment of relapse and trying to cure them the first time around is our goal.
Hello, Chris. Great talk.
Hi.
I was very intrigued by your tocilizumab data because it's not something that we do here at Stanford. And we usually measure CXCL9 levels. And although we use them as a surrogate for gamma interferon, there are macrophage-induced cytokine as well. But then we would go to emapalumab and actually target the T cell that released the interferon gamma. Now, you went after the macrophage. And I'm truly intrigued. Do we think it's the T cell, or do you think it's the angered macrophage that
yeah, that's a great question. I mean, I think the alaparumab data looks really intriguing as well. It's just at the time that we started doing this, TOSI was there was some data in the cord bloods. There was data out of Russia using TOSI with alpha beta T cell depleted. So it seemed like something we should try. And of course, alaparumab is still crazy expensive. So if I tried to convince my pharmacy to do that prophylactically, they'd probably start crying. But if we could get the drug, I mean, I still think it's a good drug. If we could get the price down, I think it would be very interesting to study more.
But you think the macrophage itself has a role in the rejection process, or it's just an amplifier?
I think it's. I mean, yeah. I don't know if it's actually doing any of the rejection itself, or it's just driving the T cells through production of cytokines.
Cool. Okay. Yeah. Thank you.
Great talk, Chris. So my question is, IL-6 is downstream of IL-1, and in terms of CRS for CAR-T, we always say, why don't we just use anakinra? And
yeah, we haven't started doing it in these patients, but it's worth thinking about. Again, in the malignant setting, your risk of doing too good a GVHD prophylaxis is they're going to relapse. But in the non-malignant, where you don't want any GVH, that would make a lot of intuitive sense to me.
yeah, definitely agree. We have seen so many CRS, and I don't know what's the relation between GVHD, but we do see quite a few GVHD 1 to 2.
Yeah.
Thanks.
It's interesting to see the data. I can tell you, neither IL-6 or IL-1 are elevated
Really?
in the haplo setting. CXCL9 is elevated, but we don't really see a correlation. I mean, we don't have this like excellent response with the emapalumab. Not so much, like you said, like the prophylactic use is impossible for cost issues, and therapeutically, we never get in time. So I don't think we have an excellent target at the moment. Maybe tocilizumab is just, I mean, it seems working, so maybe is somehow addressing the pathway, even if it's not really IL-6 the main reason.
Yeah.
Very interesting. I just got the microphone to say that I know we are a little late, but I think we had a very dense morning. So I would give a small break until noon so that we all can breathe a second, and then we can enjoy the last session of the morning before lunch. Thank you so much.
Thank you.